Okay, welcome everyone at this joint session of the EFP and the EDHF. My name is Monique Danser and I'm a periodontist at ACTA, Amsterdam University. And until a month ago, I was also in the board of the EFP. And my co-moderator is Gitana Rederine, and she is the president of the European Dental Hygiene Federation. I think we have quite some nice speakers. This one is not working yet. It's on. Yeah. Can you go to the next slide, please? It's not working. I press like this. Also not. Yes. Well, you have all seen the program. We have four, I think, excellent speakers for this afternoon. And I think it's a pleasure for me to be here as the moderator and being part of the EFP. The last few years, we really paid a lot of attention to have more awareness for periodontal diseases. And of course, you need people for that. And the policymakers are very important for that. It's all about the money. And we commissioned two papers. Some of you are probably familiar with those two: Time to Take Gum Disease Seriously and Time to Put Your Money Where Your Mouth Is. And I think these two papers concluded, one of the conclusions was that indeed prevention, diagnosis and treatment is cost effective. And the other thing is that oral health should be more integrated into the general health. So these two things are very important for us to create more awareness. Another thing, the EFP, we just made a new strategy for the coming 5 years. And one of the things that we focus on is collaborations. And I think this session together with the dental hygienist, European dental hygienist, is one important thing of that, because we have a broader public. Of course, we can have more people to create this awareness and to have more knowledge about periodontal health and how important it is, and also towards the policymakers. So I think it's very nice that we have this session here. And Gitana, maybe you want to say some words?
Good afternoon. Actually, from the bottom of my heart and from the bottom of all my colleagues' heart, I want really to thank European Federation of Periodontology for giving this nice opportunity for us to have this joint session together and to be able to see so many of my colleagues here in this hall. European Dental Hygienists Federation, EDHF, is an umbrella organization which represents 25 national dental hygienist associations in European region. It was founded more than 25 years ago with the goal to unite dental hygienists across Europe and also to make our profession stronger. EDHF works to promote high-quality service of a dental hygienist, to ensuring the recognition of dental hygienists across European countries, and also supporting harmonization of dental hygiene profession and also dental hygiene education. As core competencies of dental hygienists in Europe include essential skills, knowledge, skills, clinical practice, and also this contributes to dental hygienists' ability to provide high-quality service, safe services, and also patient-centered oral health, preventive oral health care services. Dental hygienists are really having sometimes different competencies within different countries, but EDHF, together with the national dental hygiene associations, dental educators, and dental organizations in Europe, developed common education curriculum, which really ensures the harmonization of education. And this shows that the importance of dental hygiene profession is growing within oral health team, And we, as a preventive healthcare specialist, can really contribute to better oral health. Due to some differences between countries, there are still some differences in competencies, differences in education. There are still some countries which do not have dental hygienists or they do not regulate this profession. But actually, in the heart of dental hygiene profession is oral health education. And I think today you will get a powerful tools from this session to bring to your clinical practice and to work and with your patients, ensuring the best quality of service. And here I really want to invite our first speaker, Linda Stein, who is a dental hygienist, associate professor from Arctic University of Norway. So Linda, stage is yours.
Thank you. Thank you for that, and I would like to thank you for the invitation, and it's a pleasure to be here. So first of all, I will start by declaring that I have no conflicts of interest to report. So, patient care in 2025, working evidence-based is essential. We take the best current scientific evidence and we combined it with the clinician's expertise and the patient's values and preferences. And as an appropriate response to this, the European Federation of Periodontology has developed evidence-based clinical guidelines. If we take a look at step 1 in the clinical guidelines, it's about guiding behavior change. So, according to these guidelines, the aim of step 1 is to guide behavior change by motivating the patient to have supragingival dental biofilm control and to have the control of risk factors. And we know that oral hygiene practices are crucial throughout all of the stages in therapy. And it should be re-evaluated frequently. And we have to continue to build motivation and adherence and explore other alternatives to overcome barriers. And we have to allow for the appropriate response to the next step of therapy. So behavior change is very complex. And today the current psychological approach is to the understanding of health behavior comprises the COM-B model. So this model is about creating the capability, the provision, and starts with the provision of information and guidance. Then it's about enhancing the motivation and identifying those cognitions likely to increase the behavior. And then it's about creating the opportunity and putting the motivation and the information into action. And the goal is that this behavior is repeated and is done so it in time will form a habit. So it all starts with the provision of information and guidance. But what if it stops there? What if the patient doesn't understand the information? And I think that we all have probably experienced the feeling that we have provided the information to the patient and the patient comes back. And then it all seems like the information went in one ear and straight out the other. I think maybe sometimes the trouble is that it was a mismatch between the clinician's ability to provide information and the patient's ability to process and understand the information. So this takes us to the topic of health literacy. And health literacy is the ability of persons to access, understand, appraise, and apply information to make judgment and take decisions in everyday life concerning healthcare, disease prevention, and health promotion. And it's a highly relevant topic for research, practice, and policy in healthcare, and it's supported by a growing body of empirical evidence. So if you take a look at the health literacy levels throughout Europe, there has been done some large-scale population surveys. There are some variations between the countries, from 25% with limited health literacy in some countries and 72% in others. If we take all of these countries together, we see that 46% of the adult population in Europe had limited health literacy. And it's quite an alarming number. So this can actually mean as much as every third to every other patient that we encounter at the dental clinic could actually have trouble accessing, understanding, appraising, and applying the information that we provide to them. And there has been also done some more research on the topic of health literacy. So what we know from the large-scale population surveys, but also from systematic reviews, is that health literacy is a determinant of health. And WHO thinks that it's a strong predictor of health, in line with the well-known ones as education and income and ethnicity. But in comparison to most of the other determinants, health literacy can be more easily modified. We also see that health literacy follows a social gradient, and there are some subgroups at particular risks. So people that have not finished high school, and people that have find themselves in economical difficulties are more likely to be in the limited health literacy group at the population level. And also, alarmingly, we see that elderly people and people with chronic diseases also tend to be in the limited health literacy group. And a systematic review of health literacy and chronic diseases found that people with limited health literacy have a poorer self-management of disease, and they have a harder time adapting to changing situations and less confidence in lifestyle changes. So health literacy skills are especially relevant when we deal with chronic conditions. So there has also been some research done on health literacy in dental patients or in clinical contexts. And evidence suggests that there is a significant relationship between limited health literacy and oral health behavior. Studies have found that people with limited health literacy tend to brush their teeth less than 2 times per day, and that they are more likely to miss healthcare appointments, and they have a history of more infrequent dental attendance. There are also some studies that have looked into periodontal health and health literacy, and they have found poorer periodontal health in persons with lower levels of health literacy compared to those with higher levels of health literacy. And health literacy is today considered as a moderator for poor oral health and not a direct factor for disease. So, health literacy action is required. And in their newly published Global Strategy and Action Plan on Oral Health, the World Health Organization suggests that people-centered oral health care as one of the 6 guiding principles. And health literacy is then highlighted as an essential tool for people-centered oral health care and for self-management. And helping patients develop the skills and resources to participate in the treatment actively is, as we all know, key. And we know that health literacy is also context-specific and can change depending on the context you find yourself in, and also where the healthcare interaction takes place. We also know that a lot of patients, they feel uncomfortable coming to the dental clinic. And being diagnosed also with a disease like periodontitis can also negatively impact the understanding and processing and the communication because you have stressors that negatively impact those abilities to pay attention and comprehend and also to remember the health information. So, a diagnosis like periodontitis requires a great deal, not only of the patient, but also from the healthcare provider, from the clinician. So, the patient have to understand, what is my diagnosis? What is the treatment plan? They have to know and understand the importance of self-management throughout the steps in terms of biofilm control, risk factor control, and also showing up for the appointments. And last but not least, the patients must master the recommended oral hygiene practices. So what can we do at the dental clinic to help these patients? Well, first of all, no size fits all. We know that people have different capabilities to learn and to understand. So the oral health professionals have to adapt the competence, adapt the information to the patient's competence. And we have a great history of doing a lot of good patient education. So it's important to remember that personalized information and guidance is key for these patients. And we do know so much about this disease, but it's important also that we do not include more information than necessary for each patient at each point. And it should be clear that we have to use simple words, but it's very difficult to do that, right? So use the simple and clear words, avoiding the technical terms. And the amount of information, we know that our patients, they are coming back. So we actually do have an opportunity to use each visit at the dental clinic to build on the competence for these patients. We don't have to tell them everything at once. And when it comes to visual aids to support the understanding, many patients cannot rely on only verbal information. So, for instance, using the OPG pictures to describe attachment loss, for instance, or even use clinical photos so that the patients can see how they have improved and that their hard work at home actually helps. And actually also using their own photos and their own radiograph can be quite powerful for patients. Yes, so patients often have the difficulty to comprehend and to recall the information given to them at the dental clinic. But there are some tools that have been tested out in clinical settings. One of them is the Teach Back. It's recommended as a health literacy-based communication tool. And it involves asking patients to explain back in their own words what we just told them. Or we can ask them to show us how they use, for instance, the interdental brushes that we guided them to use. Any misunderstandings can then be checked and rechecked, and this process continues until the patient can correctly recall or correctly perform the use of interdental brushes. And research shows that although we are really eager to provide information, dental professionals still have a little way to go when it comes to rechecking if the patients actually do understand. And the teach-back method has been proven effective across a wide range of settings, populations, and outcome measures. And a systematic review of the teach-back proved effective in 19 of the 20 included studies. There's also another tool that's quite useful. It's called the Ask Me 3. So before the patient leave our clinic, they should know the answer to these 3 simple questions. What is my main problem? What do I need to do? And why is it important for me to do this? And it's not actually usual to meet patients that come into the specialist clinic and they do not know why they are there. And even when they come to see the dental hygienist, they still don't know what is this disease. And what do I need to do? Well, that depends on what you have been guided. And perhaps we need to be even more clear to write down to them. Use the yellow interdental brush in the front, blue one in the back. Simple as that. And also, they have to know why it is important for them to do this. Because if they don't know, why should they bother doing it? And also research shows that if we can put emphasis on the positive sides of doing the behavior rather than the, oh no, this might happen if you don't do it, that is more effective for most patients. And this kind of tool, it builds patients' self-confidence for increased self-management and also promotes shared decision-making and addresses some barriers to care. Yeah. So health literacy, there has been many conceptual models proposed in the literature. However, very few of them have been tested in clinical settings, let alone dental settings. And this model was adapted to a dental setting from a more general health setting and tested in an RCT study. So in short, this model is that you have a health literacy friendly practice. You know that a lot of people have problem understanding and processing and using information. And you do an assessment of the patient to know approximately the health literacy level. You then get the possibility to have improved access to health care and to have more productive interaction between the patient and the dental practitioners. And you can also use this information to tailor health information and communication and the education. And combined, this will hopefully lead to enhanced capability of self-management and improved compliance, which then the ultimate goal is to have improved clinical outcomes. So this model was tested in an RCT study using a sample of adult patients who was actually on the waiting list to attend the University Dental Clinic in Tromsø, Norway. So 133 patients were recruited and divided into the intervention and control group. They all got a clinical examination with gingival index and plaque index. And health literacy level was measured. And the intervention group got the guidance and information based on adapted to their health literacy level using the tools Ask Me 3 and the Teach Back. Whereas the control group did get like general information. It was adapted to their oral health, but not the health literacy level, and we did not use these techniques. So 6 months after baseline, we found significant between group effects with reduced post-gingival and post-plaque index scores in the intervention group when controlled for baseline scores. And if you take a look at the effect sizes, they were large, both for the control group and for the, it was large between the intervention group and the control group, both for the gingival and for the plaque index. And we concluded that this model was suitable to use in a dental clinical setting. So, wider patient communication and increased shared decision-making are vital to successful self-management and improved patient outcomes. But we do know now that many patients have low health literacy, which is a barrier at the dental clinic. But we can help by using tools like Ask Me 3 and Teach Back. And we already have some quite powerful visual aids, like radiograph, that we can use to supplement words, because not all patients have the capability to understand only verbal words. And in 2025, having a health literacy-friendly dental clinic is essential. And I would also like to just remind ourselves that we have to remember to also give the positive feedback and acknowledge the patient's efforts, because living with periodontitis is demanding. And thank you so much for the attention.
Thank you very much, Linda. At the end, we will have a discussion, and then you can have your questions. There is in the app, you can ask your questions. We will see them, and we can have them at the end during the discussion. So now from behavior change, we go to something we might not be able to change, the fast and the slow patterns of gingivitis development. Professor Rodrigo Lopez from University of Bergen in Norway will be the next presenter. Please, the floor is yours. I will bring the water.
Thank you very much, Monique.
Okay.
Good afternoon. Yes, gingivitis, once again. As a brief disclosure, I have participated as a review panel and panel member of several workshops organized by the European Federation of Periodontology, and this research has been funded by independent grant. Gingivitis. You all probably remember this classical study conducted at the University of Aarhus, Denmark, many, many years ago, and published in '65. I was not even born. Probably the most, if not one of the most, if not the most influential study in periodontal practice and in industries related to periodontology. They managed to show that if you stop brushing for a few weeks, plaque accumulates and inflammation of the gingival tissues follow. But it is difficult to get from these figures, the left one on dental plaque accumulation during the first 3 weeks, and then elimination of plaque when toothbrushing was introduced. what is what? Because we know that there is a mountain there, and it's something that increases, and after 3 weeks, it begins to drop. But there were 9 dental students and 3 members of staff. So we have 12 people there, and who is who? The same with regards to inflammation. And you can see that those mountains are not equal. So something happened. If we look at the tables by Le et al., we can see the first table on top about plaque, that patient number 2 and patient number 11 start with very different amounts of plaque, 0.95 and 0. Nevertheless, when we look at the inflammation values, they have relatively similar inflammation values at the bottom. If we continue looking at this data presented by this group in 65, and we look at the amount of plaque at the end of the period without toothbrushing, these values were equal, basically, 1.8. However, the gingival inflammation at the end of the no cleaning period was pretty different. So something is going on. The main conclusions were plaque accumulation gives gingivitis, and if you brush, gingivitis disappear. This is interesting because this has set the grounds for the current paradigm on periodontal diseases, that if we don't brush our teeth, we get dental plaque that gives gingivitis. If you don't treat gingivitis, this will eventually develop to periodontitis. And if you don't treat periodontitis, this will eventually end in tooth extractions. We took the numbers from the paper from 65, and what you can see is a correlation analysis, very simple, of the increments of inflammation and the increments of the amount of plaque. We basically can conclude that the coefficient, R value, is extremely low, meaning that there is a terribly bad correlation between plaque accumulation and gingival inflammation. So it is not just plaque. There is more to it than. So I was interested in conducting a revised version of the gingival experimental gingivitis study in humans, and want to induce gingivitis in a modern, young infants without smoking, without all conditions, and see a period of 3 weeks, checking these patients once a week, and taking some samples and doing some measurements. And finally, we have the classical resolution phase, which in this case was 2 weeks, where we reintroduced toothbrushing and evaluated the results. We have 42 patients in this project, and what you can see here on the upper left corner is how they started. This is how they finish. On day 7, you can see some inflammation. On day 14, you can see more plaque and more inflammation. Finally, on day 21, inflammation in many places. But this is one example. I mean, this is after brushing again. But as you can see in this figure from the first publication of this study, there was a very important heterogeneity in the trajectories followed by each participant. What you see on the left side is a trajectory week by week for each participant. Each line is one of the participants. On the right side, you see similar trajectories for our recordings of inflammation. We use a statistical method called group-based trajectories, which allowed us to find cases which are statistically similar in their development and group them in what seems to be coherent groups. It is not an a priori arbitrary way to decide who goes with whom. Because this exercise is not new. I mean, there has been some research on this, and the interest on the heterogeneity of gingivitis has been there. The group by Leonardo Trombelli in Ferrara has done a beautiful work with experimental gingivitis. But they use quartiles, and they compared the top higher quartile of inflammation with the lower one. So in any group, you will have outliers and extremes. These techniques allow us to catch changes or difference already during the first week of development of gingivitis. So we have what we call fast responders and slow responders, and main difference is during the first 7 days. It looks like slow responders catch up during the second and third week. We conducted some analysis using a technique called multiplex, basically kind of ELISA technique, and test for the amounts of some pro and some anti-inflammatory cytokines, and conducted factor analysis to see how these run, or whether some of these load together in 1 or 2 groups. We could see that some cytokines, or levels of them, loaded in what we call factor 1, a non-organized response, whereas other loaded in a different factor we call organized response. A single cytokine, interferon gamma, loaded in both. But we saw a pretty clear and statistically significant pattern there. And they were associated with fast responders, basically. That's interesting. With those who, during the first week, develop more inflammation. We decided to do some analysis on saliva markers, more general than gingival curricular fluid. Main interest was trying to look at some biomarkers of neutrophils and neutrophil activity, like myeloperoxidase, elastase, and a marker called SUPAR. But we also include some markers of collagen destruction, because, as you may recall, the established lesion, the established gingival lesion of inflammation, is characterized by destruction of collagen in the connective tissue. And we studied metalloproteinase 8 and an inhibitor of matrix metalloproteinase, TIMP. And we found that this fast inflammatory response pattern was associated with higher levels of MMP8 myeloperoxidase and the ratio between MMP8 and TIMP1, which is basically a proxy measure for inhibition of the destructive activity. We introduced a single marker for macrophage activity, which we expected would appear playing a role later. And we used something which is called the soluble CD163, which has been used in studies of periodontitis, some type of cancer, and cardiovascular diseases, which have a pro-inflammatory profile. And while we didn't find an association with the fast or slow responder patterns, we could see that the amount of macrophage marker in gingival curricular fluid increases as inflammation increases, which is not surprising. I would like to thank some of the colleagues who participated in this and help us to make this possible. We need to build bridges. Not everybody can do everything. And in order to make this happen, we work with groups overlapping with the same interest on healing and inflammation. So thanks to them. Thank you very much.
Thank you, Rodrigo. I think your patient at least had a really good reason not to brush and justify their behavior for a while. But thank you for your nice presentation.
Thanks.
And actually from gingivitis, we are going now to chemical plaque control, and I invite Nicole Arweiler for her presentation. So Nicole, stage is yours.
Thank you. So warm welcome and good afternoon. I declare that I have no conflict of interest. And when preparing, or when I start to prepare this lecture, I ask, as our students normally do it, I ask DeepSeek for answers. And You can see it's not bad. What DeepSeek tells me, choose the right mouthwash, follow instructions, incorporate into daily routine, combine with mechanical cleaning, consider professional products. So, but I think you are not here to hear what DeepSeek or the ChatGPT will tell us. So then let me start with this radiant smiles. So we as professionals, we sometimes have fears that there's nothing left to do for us. But I think no worry, the fears are unfounded. So we see a lot of inflammation, as we saw before. We see a lot of plaque. We see a lot of periodontitis. And this is underlined by latest data of a German survey. So we see that periodontitis prevalence is again increasing from 2014 to 2033. And I think that's not different to other European or worldwide countries. So what is the problem? Our oral microbiome is important, is part of our life and is protecting us, but it's also a challenge for our teeth. So the authors here in this study concluded that teeth are the only natural non-shedding surfaces in the human body, and therefore they are a secure haven for microbial persistence. So we see then a lot of major problems on hard and soft tissues and also at artificial surfaces. So we could say the dirt must go, and more elegantly spoken, we need a good biofilm management. So this biofilm management is very complex, but it gives us the possibility to improve the oral hygiene, and the main aim, what we have, to reduce oral inflammation. So actually, we already have the golden standard. So I always say, if you have fluoridated toothpaste and you have a toothbrush, so please use it. Supplement it with a form of interdental cleaning, preferably with an interdental brush, but we have this golden standard. But as we had in the first lecture, many individuals brush infrequently, not long enough, use an improper and inappropriate brushing technique, perform no interdental cleaning. So there are many reasons not to do it. So maybe it's the low significance they give or the little motivation. And so mechanical measurements can and have to be supplemented by antibacterial agents. And the most asked or frequently asked questions is then, isn't a toothpaste with an antibacterial agent already an ideal combination of chemical and mechanical hygiene? So from my research, from my scientific knowledge, I can say toothpaste are very complex, therefore inactivations are possible. Many antibacterial agents are not soluble in dentifrices, they are rather soluble in the mouthwash. We have a stronger dilution while toothbrushing, and we use smaller amounts, so a factor 10 less in a toothpaste than in a mouthwash. So the ideal carrier for antibacterial agents are therefore mouthwashes. This does not apply for fluoride application. There still is the toothpaste, the important carrier. But Besides the mouthwashes, we can also use gels. So gels are higher concentrated in the international dosage forms. In the German-speaking regions, we have 0.2 to 1%, but gels offer a targeted delivery to areas of high-risk carriers in gingivitis and to implants. And some of us recommend to use it instead of a toothpaste once weekly, but we only have a small number of studies and low evidence so far. So what is known by evidence about mouth rinses or mouthwashes? So antibacterial agents were also addressed in the treatment guideline from 2020, so as part of step 1 and also as part of step 4. And the authors concluded, yes, antiseptics may be considered. And as agents, they recommended chlorhexidine, essential oils, and CPC, cetylpyridinium chloride. In Germany, we wrote a more differentiated guideline addressing directly home care chemical biofilm management, but it was surely based on the same international literature. And so it's no surprise our literature research came to the conclusion that chlorhexidine has, together with essential oils, a strong body of evidence of quality, and the effect was large. And CPC had only a moderate magnitude of effect, but also a strong body of evidence. And so in the German guideline, we had similar conclusions that we recommend chlorhexidine and essential oils with a strong evidence and CPC with moderate evidence. In the German guideline, we also specified special groups of patients that have a benefit from antibacterial rinsing. So you can see the list here from patients with who need special care, and you can summarize that all patients where even small amounts of plaque cause severe inflammation would benefit for additional or of supplemental mouth rinsing. So now I have here chosen frequently asked questions. So what is often asked concerning this additional use of mouth rinses. So I start with staining. I think staining, discoloration, and calculus formation is the most common side effect, especially of chlorhexidine. So what could we do? The best remedy is prevent staining by good home biofilm management, by regular cleaning, if you can. Sometimes, I hope this works, so sometimes our patients are not allowed, then chlorhexidine is the chemical toothbrush, but especially these patients and all should then avoid strongly colored or color-rich foods. So that's prophylactic, but I think all the staining can be removed by modern machines, so by professional mechanical plaque reduction. So, So the taste irritation is then a logical consequence because chlorhexidine stains and also occupies the taste buds of the tongues. So you can recommend your patients over time, staining will naturally peel off, but you can also recommend the patient to use a tongue scraper. But you should be aware that there is also a little bit of efficacy in this chlorhexidine, and the substantivity is also, it's a source of substantivity from the tongue, but if it's a problem for you, you can use a tongue scraper. So to my knowledge, there's only one solution that has a so-called anti-discoloration system that should counteract discoloration. There are a lot of studies, I have chosen two, both concluding that still there is no stain, no gain. So that most of the studies say if it does not stain, maybe or surely it does not work. It's not superior to a placebo solution. So now I come to alcohol in mouth rinses. So what is fact? We know that the normally used concentrations of 4 to 27% of ethanol, it's not isopropyl alcohol, it's ethanol, has no or gives no significant contribution to efficacy. So alcohol is rather used as a stabilizer or solubilizer of the mouthwash formulations. So some side effects that are reported is softening of composite fillings, but the study says it is excluded when used as intended. There's always a rumor about potential for carcinogenic effects, but a lot of studies now say there is no connection with carcinomas in the oral cavity and not in connection or in relation to mouthwash use. Acute intoxications are possible, but I would also say excluded when used as intended. But what about pain in the mouth? Dehydration of the oral mucosa by alcohol, it's dehydrating. So I have one study here for you concluding that alcohol containing mouth rinse does not result in worsening xerostomia. So my conclusions for alcohol are for healthy people, products containing alcohol are not a problem. Surely ethical or religious aspects are fact. There are meanwhile non-alcoholic counterparts. But for me it's important that alternatives using PEG 40, for example, as solubilizer must be clinically tested for their effectiveness. So you have to compare the old one and the new solution and also tested for compatibility. So sensitive patients report mucosal detachment from such solubilizers. Now I come to pregnancy. So we have a high prevalence of pregnancy gingivitis. So the data are fluctuating, but sure the data correlate with plaque and hormone levels. And we also know that women with excellent plaque have no pregnancy gingivitis. So yes, rinsing with chlorhexidine could help, but there is always the question, is this safe? So the package leaflets give different information. So the one says you can use if you are pregnant or breastfeeding. Other leaflets say should not be used unless the doctor has told you to do so. So I have here two studies. On the right side, an original study, and left a review and a meta-analysis, and both conclude that chlorhexidine mouthwashes, simply by reducing local bacterial load and inflammation mediators, could decrease the chances of bacteremia, intraamniotic infection and preterm birth. So this is the same conclusion here in this meta-analysis. So I think if needed, chlorhexidine rinses can be recommended even for a pregnant woman. So what about toxicity resistance? So we see in the literature there's no displacement of bacteria, so we have only a reduction and equilibrium is maintained. So we often see that the bacteria come back, also they rinse with chlorhexidine. And also resistance is a high debated topic. So far there is no clinical proof for resistance development. So the in vitro studies are very special. They have settings that they have very, very low concentrations, and only in vitro it is proven, or shown, but not clinically. But I would say chlorhexidine should not be applied on the open bone immediately afterwards, after you have a suture or you have a coagulated extraction wound. It's not harmful, but it is also beneficial. So there are a lot of studies that it promotes wound healing if you have not the inflammation or the plaque. So some years ago, there was also a high debate with a study concluding that there is a trend of increased systolic blood pressure when using chlorhexidine. But when we have a closer look at the results, so you can see that under chlorhexidine, the systolic pressure raised from 103 to about 105. So for me, this rise is hardly noticeable. And I'm not sure if rising of the systolic from 103 to 105 is really pathologic. So I think that this is really a fake news when a lot of private practices say we do not use chlorhexidine anymore because of that chlorhexidine raises the blood pressure. So this was fake news, but it gets even worse because last summer a study caused quite a stir in the social media. They said Listerine, so I name this product, gives you cancer. And there was only a few, fortunately some, but only a few analysis or press statement that the connection isn't really there. So I was also able to give statements. So for me, the claims are not scientifically tenable. The conclusions really exceed the limits of serious science for me. So what was tested in this study? The study was a part of a gonorrhea trial on 59 men who have sex with men. And these men all took already HIV pre-exposure prophylaxis. And this is, I think, certainly not transferable to our daily patient. So this is also for me fake news. So therefore, I can summarize modern and safe home care biofilm management is based on mechanical cleaning, supported by interdental brushes, and can then be supplemented by rinsing in the whole mouth with a mouthwash, or you have also the possibility if there is only inflammation localized, you can with an interdental brush ideally combine mechanical plaque control when you dip with chemical plaque control when you dip your brush into gel or into the mouth rinse. So with this graphic, I want to show that a healthy oral cavity does not require additional mouth rinses. So mouth rinses are recommended in the thickening or in the convalescence oral cavity. So you can prophylactic mouthwashes use prophylactic, and in the diseased oral cavity, I would recommend then therapeutic mouth rinses. So what this meant, so for me, therapeutic mouth rinses are the higher dosed chlorhexidine solutions, 0.1, 0 to 0.2, for only short term on special indications. And prophylactic is for me low dose chlorhexidine, essential oils, or CPC. And these are the evidence-based recommendations, a strong evidence for chlorhexidine and essential oils, and a moderate evidence for CPC. So I thank you for attention, and I'm ready for questions after the session. Thank you.
Thank you very much. Quite interesting that you indeed could attack, let's say, the lay press where these kind of statements are made, and that we can have that as a discussion as well. Well, we continue with the next and last speaker of this session, my nicest colleague of the department and Professor Dagmar Else Slot. And you will talk about supportive care of teeth and implants. And I also saw some chemical devices just mentioned, so I hope you address them as well.
Yeah,
The floor
thank
is
you.
yours.
Thank you, Monique. You're also my nicest colleague, of course. But I have quite a lot. Okay, nevertheless. Thank you for being here. We will take care that you go quickly to your opening session. Optimizing supporting periodontal care for patients with teeth and implants. It doesn't work. Okay, don't mind. We are flexible. I have a lot of conflicts of interest to declare compared to my co-speakers, and I forgot one based on Rodrigo's suggestion. I have been part of the European workshops as well, so the EFP should be under the associations. Back to the aim. If you have if you need to discuss the supporting periodontal care, you need to go back to the basic, and that's the stepwise approach. The stepwise approach was introduced in 4 steps, and it was introduced by the EFP guideline. The British introduced a kind of step 0, what was a prologue before the stepwise approach. What I think was nice, because they used the classification as a step 0. And what we need to do as dental care professionals to guide our patients from step 0 up to step 4. But what we also often see that patients somewhere in the treatment protocol fail. So we as dental care professionals need to help them to guide them through up to the step 4. So we take them through the stepwise approach. This stepwise approach was introduced in 2020 by a very important paper, what is more or less the basis for the stepwise approach. And if you go back then to the aim that is given to you as a speaker, is optimizing supporting periodontal care for patients with teeth and implants. That's about step 4. But if you want to discuss step 4, you need to know what is in step 3. And if you go back into the guideline and you see in step 3, they say you have to re-evaluate after step 3. And what do you need to re-evaluate? Whether there are no pockets bigger than 5 millimeter with bleeding, and there are no pockets bigger than larger than 6 millimeters. Then you are eligible, and a patient can be transferred to the periodontal care supportive period. So you need to take care that step 3 is tick the box, and you were successful, then you can transfer the patient to step 4. In step 4, there is a definition given what is aiming for step 4. And it said that you should prevent your patient, or together with your patient of course, for recurrence and progression of periodontal disease. This is for all patients. And it's a combination of preventive and therapeutic interventions. Again, they go back to the endpoints that were given previously. Based on the guideline, it said that visits should be in an interval of 3 up to 12 months based on risk assessments and, of course, of the periodontal condition. It also said that adherence to those visits is crucial or essential. Crucial is a bit of a ChatGPT word, for long-term stability. And during those visits, it is needed that you provide re-instruction on mechanical cleaning, but must be given based on the needs of the patients. And as said before by Linda, not one size fits everyone, so you should be very tailor-made. It also said that there is, besides the professional mechanical plaque removal, there is no need to support this with photodynamic therapy or lasers. Surprisingly, in the schedule you can see it's still in the schedule of this meeting somewhere. Based on the tailor-made intervention, you should provide your patient evidence-based advice, also explained by Linda before. And that should be based on your clinical expertise, the scientific evidence, the available product, and the wish of the patient. And that includes toothbrushing and interdental devices. The highest level of evidence is when that's recommended to use interdental brushes. And if they don't fit, there are other interdental devices that can be used. Although there is not much evidence to support floss. However, DeepSeek is still recommending it. That's what Nicole showed us. For the powered toothbrush, when it comes into the use of powered toothbrush during step 4, they can be considered. The reason is that there are only limited studies for powered toothbrushes during this period in the group of supportive periodontal care. When it comes to chemical products, that's what Nicole also showed, there is some evidence for using a specific toothpaste. Actually, if you look very into what's available at the moment, it's mainly stannous fluoride with hexamethyl phosphate because triclosan is not on the market anymore, and chlorhexidine often is not for long-term use because it has not enough chlorhexidine in it. Regarding the antiseptic mouthwashes, that's what Nicole also showed you. Chlorhexidine is very good for the short term, for the long term, essential oils, or maybe cetylpyridine chloride or CPC, also called in the short version, is an option. Are products to choose. There are also other sprays, for instance, but that's only on open recommendation because there is not much evidence for that. It's also that for micronutrients, there is only, and prebiotics and probiotics, there is only very limited evidence to support it on a scientific base. So therefore, there is no clear recommendation in the guideline to use this during phase 4 for our patients. If we transfer then what we have based on the risk control, then we see that tobacco use and smoking cessation is extremely important. That has been recommended to provide smoking cessation. There is also suggested that diabetes control can be suggested, but maybe from a dental care professional point of view, it's better to refer to the general physician or the specialist, because very often, as Gitana showed, at least for the dental hygienist, it's not our scope of practice. So let's go back to the smoking. Smoking cessation is one of the most important tasks if your patient still smokes during phase 4. If we look at the data in Europe, we see that still approximately 24% of the European people smoke. Some countries smoke a bit more, some countries smoke on average a bit less. A new kid on the block is vaping or the e-cigarettes. There are not much data available, but what I could find for Europe, on average 2 to 2.7% of European people use the e-cigarette. Very recent, last week, there was a study in the Netherlands regarding young people up till 25, and 25% of them has at least last year used the e-cigarette or the vape once. What means that these numbers are maybe a bit on the low side. And this vaping or this e-cigarette is a very interesting phenomenon. It was presented as a way of quit smoking of regular nicotine devices. If you go, for instance, to the NHS website in the UK, vaping is still considered a product to quit smoking. They even provide tips for successfully change from smoking to a vape. If you go over the ocean to the US, the Centre of Disease Control advise something completely different. They say there are health effects of vaping. And if we look back to what's going on in Europe, the European Commission has even a directive for these e-cigarettes. And there is a committee, the SHARE committee, who already in 2021 provide recommendations, as you can see, a bit of European style with the words, using like the words like moderate or weak, giving information and giving a recommendation regarding these vapes. What they also showed already in 2021 that vapes are strongly addictive, and there is weak evidence for quitting smoking by the use of vapes. So, if we take this all together, based on the data from 2021 from the European Commission, I think there is a need for updating the risk, and I'm for sure they will doing that. There is a big discussion about the disposable vapes. For instance, in Belgium and Luxembourg, they are not allowed anymore. There is a discussion about flavors. For instance, in the Netherlands and Belgium, it's not allowed to use flavors in vapes. In other parts of Europe, they are. There are a lot of vapes coming not comply with the European regulations because they come illegally into Europe with other compositions which are even more harmful than they are by the ones we know and we have tested and they are regulated. And for sure there is a need of advice. So this is work in progress. So going back to those people who smoke, and you are in stage 4. What is a really nice tool, and that's what Linda told, we need to have to engage our patients. And one of the things that's really nice are Omni calculators. There are hundreds of calculators, and they even have collection of smoking calculators. And you really can bring this to your patient, because you can calculate a pack years. That's not too difficult. You can do it also by yourself. But there are also calculators, for instance, for the smoking recovery calculator. And you can really make this personally. So you can put in the country, what the gender is, what the age is, when the person starts to smoke, when the person quits to smoke, and it even gives an advice regarding tooth loss risk. Because if you look into what's behind this calculator, it says that the first year after quitting smoking, it's twice likely to use a tooth compared to a non-smoker. And that provides data. This is not something a saying by someone, but this is based on scientific evidence. So even you can click on the data they are based this calculator on. Even more, they say after 14 years of quitting smoking, the risk is like you have never been a smoker. So these are tools we can use for our patients to communicate with them and to engage with them on their personal level. If we go back to the guideline, one of the other things that what's often said, and that's for instance with our period trainees, we have physical activities, dietary and lifestyle modifications are suggested. The effectiveness regarding oral health or optimal oral health is not as big. There is an unclear effect of this. Of course, there is effect of improving your physical activity, I should do, your diet maybe as well, and lifestyle, but that's for general health, and that's also a very good reason. If you look to the periodontitis guideline number 4, one of the most important things is the time point of the prosthesis. And what is said is that one of the things most important said is that the self-performance of oral hygiene should allow self-care products. I recall, as a dental hygienist by heart, this is not often the case, I recall it quite hard again, prosthesis should allow self-care. And I'm rather sure that the majority of those who made those prosthetic solutions are not in this room. But this is a problem we face on a daily basis. And it's in the guideline you should comply. So now we have something to show that if it doesn't complete, we can say you don't complete to the guideline. This is also applying to dental implants. In the guideline, there are general considerations for when incorporating dental implants. It provides 4 very good items to consider. And although this kind of meetings is very often about techniques, it is seldom regarding these considerations. And I think it's very important because these are important considerations for maintaining during the step for our patients. So if we take the balance between implants and natural teeth, I think the natural teeth are still the way to go. Nevertheless, the EFP provide us a peri-implant guideline as well. And if you look into the data of the peri-implant guideline, when it recommends professional mechanical plaque removal, it is funny that based on the evidence recommendation and the other additional recommendations, it is the hygienist who is placed as first to provide the professional mechanical plaque removal in the line of all the other dental care professionals. Well, very often the hygienists are the last ones, but in this guideline we are the first ones. This also applies when it comes to how to provide this mechanical plaque removal with ultrasonic, with the tips, with the air abrasives, titanium curettes, or the brush. It's more or less everything you can use. Again, it is the hygienist who is positioned first to do so. It is also said that there is no need for the use of a diode laser. And also the combination of the air polisher with the conventional mechanical prophylaxis products, there is no need, again, for the hygienist. And when it comes to the endpoint, and when the endpoint is not reached, the interval should be modified. And that is also something, again, based on different dental care professionals, but the hygienist is positioned at first. And after we have heard the EFP guideline, we have heard Nicole a bit about the German guideline. I like to provide you the guideline by Dagmar. This is my view on the world. And I will be very clear. Those who drop the bomb should take care of damage control and not put it over the corner to us. For me, there is no discussion when you incorporate dental implants. It should always accommodate self-preferred oral hygiene. I rank myself with 3 stars for this. Nevertheless, very often studies said and closed, more research is needed. I think what is needed, we need more research on how to maintain dental implants. Not so about how to place them, but I prefer how to maintain them. That's so limited. We need more guidance, what actually we should do with our patients from our side and what we should advise to our patient. So if we go to this balance, maybe the balance is this, or even this. I strongly believe we should maintain teeth as a primary goal, and then we have a healthy mouth in a healthy body. Thank you.
Well, nice words ending this very nice presentation with the Dagmar guideline. Can I ask all the presenters, please, on the stage for the discussion? Yes. Yeah. Yeah, when I start with you, I think, Dagmar, as the last speaker, I heard a lot of things. It's very nice that you had the stepwise approach. I think most of us work, or all of us work with it, I hope. We should by now. And what I did miss is the guided biofilm treatment in the supportive therapy. What do you think of it?
There are some studies regarding the guided biofilm technology. There are even studies about using it during the active phase of periodontal therapy, so during step 2. But there are also studies regarding step 4. What you see that there is some evidence, and it's mainly that patient satisfaction is higher ranked than the conventional therapy. But there is not much evidence, and it's not in the guideline when it was developed in 2020. It was not incorporated. It will be in the future. It will be incorporated, and it will be ranked in a recommendation.
So less time, no, and better results?
Better results depending what your outcome is. Your outcome on patient satisfaction, then it's a different outcome than on clinical measurements.
Yeah. Thank you.
And I have a question for Linda. We understand that health literacy is a barrier at the dental clinic. So can it be also an asset?
Yes, definitely health literacy can also be regarded as an asset. And I would actually say that if we have a dental clinic with staff that's aware of that many people have limited health literacy, then we can actually change the narrative from a barrier to an asset by guiding the patients, adapting to their levels and building on confidence and knowledge increasement. Yeah. So I think some countries, Norway, definitely have had a national strategy now for all of health literacy, with focusing on having health literacy-friendly organizations. That's hospitals, dental clinics, pharmacies. So yeah, so it can definitely be an asset if we are aware of this, that many people have low health literacy.
Thank you, Linda.
Yeah, I stressed in the beginning the importance also of prevention. Rodrigo, for you a question. You showed that there are different responses to the biofilm. First of all, is it also related to periodontitis? First question.
Well, it's very likely that many will think something like that, but we don't know, actually. This is not a continuum. I mean, we know that even though everybody experiences gingivitis in different periods of life, relatively few people experience periodontitis. And very few, 10, maybe 12% experience periodontitis that can threaten tooth survival. So we don't have data for that. We actually know very little about gingivitis.
So you don't think it has implications for the treatment or for prevention?
I don't think we know the implications of groups of people responding differently to gingivitis today. Some people may think that this implies a higher risk of experiencing tissue destruction and periodontitis, but on the other hand, it may be protective and may also have nothing to do with it. So I would be more concerned with patients who are not able to mount an effective gingivitis somehow, which is the case we see with some very severe, rare syndromes where the inflammatory response is not commensurate with the destruction.
But then there's also the immune system that is not working in those kind of patients, you mean? Yes, okay, thank you.
And I have one question to Nicole. Does it make a sense to use a toothpaste instead of applying gels or a mouth rinses with the interdental brush?
Good to ask. Some patients do that. They use toothpaste in combination with the interdental brushes, but it has too many abrasives, or there are too many abrasives in the toothpaste, so that's really harmful for the tooth, so you should not use it. You should dip it into mouthwash or into the gel. So, yes.
Thank you, Nicole. I think this will really enhance our oral health literacy and will help really give a best advice to our patients.
Yeah,
Thank
maybe
you.
I can comment a bit. That's maybe also one of the suggestions, that you should use interdental brushes before you start brushing, instead of the other way around.
You don't agree?
You don't agree? That's a good.
Yes, but it's also argued that you clean then the interdental area, but then when brushing, you press again the plaque into the interdental area. And for me, I would not recommend, but there are so many possibilities, and it's very individual, not all one size fits it all, but I think it's more important to clean the plaque from the surfaces than you press it into the interdental area, so then you have nothing done. So you have again plaque in the interdental area. So therefore, but there is not only one solution, I would say, so it's very individual.
I think it's also depending on how the interdental area looks like.
Yes,
How the papilla looks like.
that's true.
As long as you do both,
I
right?
think here we can conclude this session. I think we heard a lot of the patient care, different aspects, step 1, step 4, but a little bit of step 3 as well. And of course about the development of gingivitis. I really would thank all the speakers very much.
Thank you very much.
Thank you.
Of course you,
Thank
Gitane, as my
Thank
co-moderator.
you, Monique.
And I think in a few minutes the opening ceremony will start.
Oh.
So we'll all see you there.
It's
Thank you
straight
for
ahead.
watching.
And thank you everyone
straight
who was
ahead.
here the 1.5 hours with us. So thank you.